Hello, and welcome to the Viva La Vulva podcast. I'm your host, Dr. Cara Quant, and I have two special guests on the podcast today, both friends of mine. I met Dr. Erica Davenport in the Blue Scrubs. I met her back in medical school. So we went through all medical school together. And then Dr. Brittany Johnson, who is in the gray sweater. She is colleagues with Dr. Erica Davenport, and they went to residency together doing OBGYN. So thank you both for being on the podcast today.
Thank you for having us.
So I wanted to bring us on together to talk about healthcare disparities amongst minority women, especially in childbirth and pregnancy, and me, who doesn't do childbirth or pregnancy, in just life in general for patients. And so I wanted to have that discussion because there's been a lot of talk around healthcare disparities amongst minority women. There's been shows like The Resident that has come out talking about these problems. Serena Williams experienced it. So there's just been so much talk about it right now, and I wanted to bring us all on as doctors, as Black women physicians, talking about this topic. Sorry, I am pushing my notifications off right now. So I want to start out with talking about a statistic that I've heard before, but I think it's still ridiculous, that Black women are 3 to 4 times more likely to die a pregnancy-related death as compared with white women. And so you guys being OBGYNs, you considered a not community hospital, but what would be the hospital, without saying it, what would be the hospital considered that you guys did residency at?
I think that our hospital will qualify as definitely a referral center for patients primarily of low socioeconomic status, for patients who do not have adequate health care, who have advanced stage disease, who represent all of the people who are at risk of potential healthcare disparities.
Yeah. So you guys, I feel like we're in the hub of it. You guys saw many of the minority women that were advanced in their diseases, or that hadn't sought out health care until seeing you guys.
Exactly.
So how is that as a Black woman and as a doctor, knowing those statistics and being in the training center that you guys are at?
Well, when you're training in with that type of population, you don't have a sense that these patients, minorities, are really at the higher risk, because everyone is high risk, unfortunately, because we were that safety net facility. Having now graduated from residency and seeing and being in the community, you do realize that there is definitely a disparity or gap between people who have access to healthcare and the patients that we served. And so when you see these numbers in real life, it's very daunting and astonishing, because as a resident, we see high risk all the time. So we were trained well, and we were exposed, or we knew how to address it. Now being in the community, you realize I don't think people were trained adequately, or there's more racial undertones that are prevalent in medicine that we necessarily didn't deal with, because being a people of minority, and constantly everyone was of minority background, there wasn't really a difference in terms of how we treated our patients.
So, Dr. Davenport, so you see a difference in the way that you practice in residency versus you practicing in fellowship, because they're different settings.
Correct.
Yeah.
Part of it is that now that you're at the community, because I trained in a referral system, like I said, everyone's high risk. When you're in a hospital that is not comfortable or not let's say, familiar with the high risk patients, and or it's not necessarily a high or predominantly minority population, you do see discrepancy in terms of how people are treated.
I see.
I think that this is becoming an issue because the population, the dynamics of the population is changing. And so as healthcare providers, even if you don't identify as being a minority, if you are a white physician or a non-minority physician, you will have to take care of these patients at some point in time as an OBGYN. And right now, 50% of the women who are getting pregnant or having children are of minority background. And within the next 30 years, the majority of the entire population will be minority. And so I think it's very important for us to recognize that there are disparities and differences with different patient populations, and we need to start addressing these issues because they will inevitably be forced to face the issue.
Yeah. And I don't know if you guys saw the Resident episode where it was a white doctor, an Indian resident, and a Black patient. The patient was giving birth. She had a C-section. It was almost like a crash C-section. And then she had complications from the C-section. And she was bleeding, or she was bleeding from her bladder. And there was a lot of discussion about, hey, the resident saw that the doctor wasn't paying attention to the patient, but the patient was having a lot of symptoms. And it wasn't until the end that the patient basically died because she hemorrhaged to death. And the doctor who was taking care of her, a white physician, was like, I've been doing this for a long time. I understand what's going on. And, to the resident, you don't need to worry about this. Like, I got this. And so she ended up dying because she wasn't listened to. Her symptoms weren't listened to. And Dr. Johnson, as to your comment, like, yes, there is a point where it has to be faced that white doctors listen up to a Black patient's symptoms.
Exactly. You're pretty much touching on the issue of implicit bias, and this has been like a major area of concern, and area that we need to recognize that we all have our own implicit bias, either towards or against people for whatever reason. And as long as we're aware of those issues and our biases, that we can hopefully address them whenever we're faced with that, whatever that bias may be, whether it's towards people of different sexual preference, racial background, ethnic background, language barriers, habitus. These are all things that we need to recognize that we may have a bias against, and we may treat them unconsciously differently and not do the same things that we would do for someone that we may identify with.
And the example you gave with the show, which unfortunately I haven't seen it, is exactly what happened to Judge Hatchett's daughter-in-law, in which she had a complication during the surgery, and it wasn't recognized until it was too late, until she unfortunately demised. And the same thing with Serena Williams. It's part of it is implicit bias, part of it they're not listening. They don't feel they don't give the exact same care that they would of a person who wasn't of a minority background. And I think like Dr. Johnson was saying, that this is very important, and people need to be more aware that numbers don't lie. We can sit here and say, oh no, like the gentleman in the or the doctor in the show, oh, I've been doing this for several years, I know what I'm doing. But if that was the case, then 3 to 4 Black women wouldn't be dying at a 3 or 4 times higher rate than white women. The numbers don't lie. So we need to really sit down and have a full discussion and be open and honest about, what are the barriers to prevent us to what is preventing doctors from giving the same care to someone who's of a Black or Latina background.
Mm. Well, what do you think some of those answers are, or what do you think some of the problems are? So, Dr. Johnson, I know you're saying implicit bias. That is one of, of having an unconscious bias about somebody through years of programming and, not knowing that you're giving different care with another person. But like, what do you think some of the other issues are that are causing Black women to die at a higher rate than white?
There's a lot of different factors, a lot of different levels to the issues. Um, there are patient factors. Some people think that, oh, because they're Black or because they're Latino or because they're Native American, they're just going to have these bad outcomes and we just need to accept that. That's not the case. There are some things genetically that certain ethnicities or genetic variations that occur. Black people may be more prone to sickle cell disease, and we need to be able to recognize that as healthcare providers, that this is something that we need to screen for, that we need to make sure we're treating our patients adequately if we are aware that there are genetic variations. We need to understand patient factors in regards to whether or not, they have different types of diets, different types of attitudes and preferences about certain things regarding their healthcare. And we need to be able to identify and recognize those differences and not say that the patient is being difficult or that's just their problem. We need to be able to figure out how we can work together to be able to have a successful outcome. There are issues on the healthcare level in regards to access to care. Even though we have the new Affordable Health Care Act, there are still places where you have to drive an hour or 2 hours to get adequate prenatal care or for certain services. And now with the new administration, that may not be the case in the next few years. We may not even have access to affordable health care. And then there are issues in regards to the healthcare provider itself, ourselves, that, like I said, we have biases, and we just need to be able to understand all of those different factors that are affecting these disparities.
Yeah. I actually read a statistic. I don't know what the exact statistic was, or maybe it was more just an observation that Black people in general, their pain isn't as believed as other or as white people's pain. And so there is a bias about pain levels, and you can tolerate this or you're being dramatic about this. And I just saw a patient yesterday. He had a sprain of his ankle. He was in a lot of pain. He had a lot of swelling in his ankle. And he was like, ibuprofen isn't really helping me. And when I came in a couple days ago to request, just something stronger, he wasn't given that because it was like, oh, well, you can deal with this pain. Your pain is fine. And I'm
Or
like, that's the big thing. That's the big thing of us not being able to deal with people's pain adequately. And I even remember patients when I was in residency, sickle cell patients that came in pain crisis, and it was usually Black women coming in for, their sickle cell, and us, I feel, not controlling their pain properly. And I remember a patient came up to me and she was like, just give me the medications that I am requesting. Like, I've been here many times. I know what my pain is. Like, I know that this helps me and this helps me. And that wasn't believed. They're like, no, we can control her pain. We know what to do. And so I just feel like people's pain isn't controlled because there is a bias about believing someone's pain, which is a subjective
Exactly.
thing, but it's still, it's still believing and trusting a patient when they're saying that they're in pain.
Exactly.
Right.
I think that everyone, in regards to healthcare providers, it should all be like, whenever you start working for whatever group, hospital, whatever, you have to take an implicit bias test. So you can recognize that you have these biases. And hopefully when you do get that patient who comes in complaining of pain, you could recognize, okay, I do have a bias against this person. What would I do if that person looked like this?
Yeah. Yeah.
And And we have to remember as providers, minority and not minority, is that there's a long history of mistrust in the Black community. So when you go to the doctor and like you said, you're not being heard when you're in pain, that builds on top of when now you're pregnant and should I speak up? I don't know if I do speak up, will they even listen? Like this occurs from childhood all the way up to when you get care as you get older. And so I know there's other factors like access to barrier, genetic dispositions or predisposition to certain hypertensive, diabetes diseases. But at the same time, studies have shown, regardless of the social economic status, whether or not you're a millionaire, Serena Williams, very educated, it doesn't matter. You still have the worst outcomes than someone who's white. So it's not about access all the time. It's not about your genetic disposition. It's the things we don't like to talk about. And it's a racial factor. A lot of this is solely based on race and so, it worries me because as a, educated Black physician, I want to make sure that when I have a child that I'm going to be taken care of. But there's no guarantee of that. No matter, and I'm an OBGYN. So,
yeah. I mean, and I think that really about myself. I'm like, can I be, I say played, but like, can I be a statistic? And it's true. But I'm like, I don't know. Will I be able to? I guess I pray that I will be able to speak up when I need to speak up and like advocate for myself when I need to advocate for myself. And I feel like that is maybe one of the biggest things on the list of like of a solution. Like we just have to advocate more for ourselves, and we have to trust that our pain or our symptoms or our stomach pain, or, vomiting, and that's real, and it's coming from a place of a problem and it needs to be addressed. So
exactly.
I pray that is the case. And me not being a statistic.
I think Serena, when she wrote her article about her experience with childbirth and her feeling as though she had developed another clot in her lungs, she wasn't being heard. And so she continued to tell someone, I need this, I need that. And I think that people should be encouraged to speak up for themselves, and that if you're not getting the response that you would expect based on whatever complaint or presentation that you have, that you continue to push the issue, because you can't just sit down and say, oh, they said it's okay, so I just need to be quiet. No. If you feel that something is wrong, I would encourage everyone to speak up and say something. And I would hope that patients and women, minority women especially, a lot of Latina women, it's very uncomfortable. They come from a society, it's culturally acceptable for if someone who's considered in a position of higher authority, being the doctor, that whatever I say is what should happen, and they don't question it, and they're not going to say anything if they're experiencing something different from what I'm saying.
Yeah, and I think it definitely is education for sure. And I think that even the education around medical literacy, like us describing something and it going and all the answers or all the questions being answered for the patient. Like if I say that you have diabetes, the patient asking like, well, what is diabetes and what does that have, how is that going to affect me, and what do I need to do to control it? And, so I feel like there has to be a dialogue with the patient and the provider as to what is the problem with my disease and how can I help to make it better.
Yeah, a lot of times I hear it's the sugar. I have high sugar, and it sounds innocent, but diabetes is really like a silent killer. And if you're just calling it sugar, my sugar is bad, like you don't actually understand like the power and the effect that it can have on your health 10, 20 years down the line or during your pregnancy.
Yeah. Right. And I think also that was one of the major reasons why I became a doctor, is that I'm very interested in empowering women and educating them. And I feel like the exam room is the best avenue versus like, being a teacher in the classroom, is because you have their attention and you have that knowledge where you can say, hey, you have this and this is something as simple as gonorrhea or chlamydia. Like, what's the long-term health effects? Yeah, people get STDs a lot, but there are fertility long-term consequences to that. And so that's how I've tried to semi-address some of these issues by education and by allowing people to have more power or more control about their healthcare, because the more informed you are, the more the better you can make decisions regarding your care.
Yeah. Do you guys ever encourage patients to ask more questions, or to, I don't know, look up information, or like encourage them that, hey, I'm on your side. I am your advocate. If you have a question, like, please ask me, and please, speak up.
It's definitely important for a patient to trust their healthcare provider. We're not asking you questions about your drug use or alcohol use or your living environment or what medications, because we want to judge you. And hopefully, if you feel that I'm coming from a place that I'm trying to help you, that you would be comfortable and honest to share whatever issues, whatever I've explained about your prenatal care, your obstetric or gynecologic care, that you would ask questions and be honest to answer whatever information that I would ask of you. And so I think that it just goes back to that rapport. You really, as a patient, should be looking to, you can shop for doctors. Like, just because you were assigned to someone doesn't necessarily mean that this is the person that you're stuck with. If you do not feel comfortable with whatever provider you have, you can ask, I would like to see another doctor, and it's on that doctor to refer you, or you can go through your insurance or whatever avenue to get a different doctor. You are not forced to have whichever provider.
Yeah, and I say the same thing for patients. I'm like, you can switch doctors. I don't know if you know that, but you can switch doctors. Like, you could just ask for a different doctor. The one that you're assigned to does not have to be the one. And if they're not addressing your questions
and your needs
and your side effects from your medications, like, then you could go to a different person. It's okay. They're not gonna have any hard feelings, and you are getting the care that you deserve.
I tell patients all the time. So it's a very, you see one patient of another colleague's, and if you have a better rapport with that patient and they say, hey, I want you as my doctor, that's just how it goes. And it goes both ways. If another colleague sees one of my patients and they have a better rapport, because at the end of the day, it's all about patient care. So if you're not getting, like you said, what you need, then you need to move on to another physician who can. And when I see a patient, regardless of their background, regardless of their age, I always assume they don't have, or I don't want to say that they don't have the knowledge, but I always start with the basics, even just explain the menstrual cycle, because you'll be surprised that lawyers, people, who graduate from high school, the education is, and when it comes to your own health, can be very limited.
Yeah. I mean, that's what comes back to medical literacy, right? Like, people knowing what is going on for them. Like, if they get a diagnosis of high blood pressure, or if they get a diagnosis of chlamydia, gonorrhea, like, what does that mean for them? What is it? Like, what is the treatment? So there is definitely health literacy, and being empowered to ask questions about like, what is going on for me.
Right.
Yeah. Because I feel like, even I've had a patient that I had diabetes, had really bad diabetes, needed to be on medication, but more likely needed to be on insulin. And she was pretty young, and her parents did not want her to be on insulin. They're like, this is bad, this is wrong. And I had a 30-minute conversation with both the parents and with her about insulin, and it was never started. And I was like, please ask me questions. Like, please, I can give you resources. I can do this. And I think that there's times where we will try and try and try, and for a patient to ultimately make up their mind and do or not do the therapies that we are recommending. Yeah.
But you at least have to try, right? I mean, our job is to educate and inform, and it's patient autonomy is a real thing. So if they don't want to accept the treatment, that's on them. But as long as you've done your job and your due diligence in terms of educating them and prescribing, then it's up to them at that point.
Yeah. Have you guys ever seen a patient that is minority and had that implicit bias that was playing out that you didn't necessarily recognize until after you saw the patient or until you thought about it? Like, are there any scenarios like that where we're
Where I have
also
the bias.
we're
Sorry.
also like succumb to some of the biases?
That I've recognized when I'm taking care of a patient that I have a bias,
Yeah.
may have a bias. Um, I would like to say no, but I'm pretty sure. I've definitely had to check myself and make sure that I'm providing the same level of care that I would to my mother or my grandmother, my sister, brother, whomever. Um, and I think it's just natural. I don't think that um, we should feel uncomfortable or um, feel bad that we have it. I think it's a natural thing. We watch TV. We have these influences that create the person that we are today, and I think that I just have to remember, what would I do if this were my grandmother? And that's how I have to treat every patient. And that's, there are some patients who are going to be quote unquote considered more difficult. But I think that at the end of the day, we have to check ourselves. If we need to call another colleague to come assist us, um, we have to do whatever we can to make sure that the patient is getting the best care possible.
Mm-hmm.
Agree.
Yeah. Um, let's see. What else? I mean, I know that we were having, Dr. Johnson and I were having a conversation around this and how it is really close to our hearts. And I know Dr. Davenport also, but that it really is a subject that is close to our hearts because, at least for me, like I have seen both sides of the story. Like I have seen my friends of mine not want to go to the doctors, black friends of mine not want to go to the doctors because they're like, well, I can deal with this on my own. Like I know I have a high blood pressure, but I can deal with this on my own. I can exercise, I can eat right, I can do all this stuff. And they're like, I don't like the doctor. I don't want to go to the doctor. I don't want to take any medication. Like this is, I could do this on my own. And then I see the other side of the story where it's like there are people that have complications from the issues that weren't addressed, either because they didn't trust the healthcare community, they didn't trust their doctor when they were going in, they didn't trust the therapy that they were recommending. And so I have seen, myself as a Black woman, as a physician, I've seen both sides of the story. And I guess I'm sympathetic or empathetic for both sides.
Right. I mean, it highlights the fact that there's just mistrust in the healthcare system. Why, if you're in pain, if you need help, why would you not go seek care? It's because you don't think you're going to get the care that you deserve. And then unfortunately you wait and wait until now you have poor outcomes. And then now they link it to being a minority with poor outcomes. But it's multifactorial in terms of this healthcare system because race is not black and white, unfortunately, and it influences a lot of our decisions in ways that we may not recognize or should recognize.
Mm-hmm.
Yeah, I know that we had a discussion before, and it's very hard because I've had patients who I've taken care of, and they are Black or would be considered Black if you saw them, and they're yelling, I don't want this type of doctor or whatever, or they may seem like almost to the point of like belligerent, or and it's hard for me as a provider to take care of that person, but it's also at the same time I'm like, we're already like 2 steps 3 steps behind, and I need to do whatever I can. I need to bend over backwards to make sure that I take care of this patient. But sometimes we're fighting each other, and you can't fix everything, but I think we just need to recognize and try to do everything we can.
Mm-hmm. Yeah. And I think also that what I have experienced is that patients enjoy Black patients enjoy seeing me walk into the room. And oftentimes they've said it. They've been like, oh, I'm happy to see a Black doctor is taking care of me. And I think that, not for whatever reason, but there is more of a trust when you have your race that's in front of you that's treating you, compared to somebody of the opposite race. I think that there is more of a trust that's there compared to them not being the same race. And so a solution to these health disparities is bringing in more minorities into medical schools, to be trained and to help train colleagues that are white in, hey, this patient is really in pain, or this patient is having complications, or this patient is, to advocate for their race, which is unfortunate, but I think that that is also one of the solutions that will help.
Right,
I
I
definitely
agree.
agree.
Oh,
Go ahead.
I was going to say I wholeheartedly agree because, just taking a step back in terms of when we look at healthcare, when we just look at our society in itself, being a person of color, you're more in tune to your race and what it means. And I say that in the sense that, not to say that doctors who are not of minority background are not equipped to deal with minorities, but I think there's these certain nuances that they may not be aware of. And I'm being very diplomatic about it. But for example, I have an attending or another colleague who didn't know that there's a different screening for colonoscopies in African-American patients. African-Americans are higher risk of getting colon cancer, and so you have to screen them earlier. So not to take away that she's not a bad doctor or anything, she just didn't know. But I think when you are a person of color, you are more, or you can be more aware to the nuances or the different disparities between different minorities or different races, and you can address those concerns earlier, if that makes sense.
Yeah.
Yeah, and there's definitely a lot of evidence, and it's not deniable that outcomes are improved when you have someone, a healthcare provider, that is of the same cultural or language background as a patient. Like, it makes a tremendous amount of change, and like, the outcomes are just better. There's no refuting it. And so that's one of the solutions, like probably number one or number two on the list in regards to improving healthcare disparities, is that we need to increase the diversity in the healthcare system. Ethnically, racially, linguistically, we need to have a very, very more diverse group of healthcare providers.
Yeah. And I know that, we're in California, and so there's a lot of Spanish speaking patients that we're seeing. And I will use everything. So it's either I'll use a trained interpreter, or I'll use at this time we can do video interpretation, where somebody pops up on the screen and can translate for us. And those are our options at this point. But I know from talking to patients, and from just seeing it in real life, that patients feel more comfortable with their own language. Like, even if they have an interpreter, yes, that's good. That can help to interpret. But I feel like there's something on a deeper level in terms of, like, I don't know, body language, or there's things that we can't pick up by using a translator to help us in this dialogue. I mean, that's what we have. But I don't know, like, it makes a huge difference when someone can speak the same language as you, can look like you.
Definitely.
Yeah.
There are other solutions that we can try to use in our toolbox. The implicit bias, I think, is key for nurses, laboratory technicians, doctors, anyone who is in charge or plays some type of role in patient care needs to take an implicit bias test. And it needs to be something that they take regularly throughout their career, because these things can change, or just the reminder that this is something that I'm still, I still face. We need to promote research around healthcare disparities. We need to raise awareness amongst our colleagues. We need to be able to have Dr. Davenport had a conversation with her colleague about the difference in recommendations for screening according to different ethnic and racial backgrounds. Like, we need to be able to have this communication amongst ourselves so that we can raise awareness about the prevalence of the disparity. We need to have more, like I said, more research, and we need to educate our patients to voice
Advocate
their
for themselves.
to advocate for themselves, to be a part of their healthcare.
Yeah. And I know, Dr. Davenport, you sent me a PowerPoint of the healthcare disparities amongst minority women. So we're, or just the healthcare disparities in childbirth, right? In pregnancy?
Correct. It was a CDC, I believe, report, and it looks at the maternity mortality rates in selected countries and compares the U.S. mothers compared to other countries. And just in general, the U.S. has higher mortality rates compared to other countries. But then when you also break it down by ethnicity, Black women by far have the highest in comparison to white women. So when you look at all U.S. mothers, and this is deaths per 100,000 live births, you're looking at 14 deaths per live birth in general. But 43.5 of that number is African Americans. So 43.5 women die per 100,000 births compared to the average U.S. woman. Does that make sense?
Yeah. But what is the number for the other women?
So when you look at U.S. non-Hispanic white mothers, is 12.7. So 12.7 compared to 43.5. Yeah.
Yeah. And I was actually looking at the PowerPoint that you sent me, and it was like for everything, for deaths, for gonorrhea, for infant deaths, for, I mean, there's a lot of, numbers that are pretty striking for Black women compared to non-Hispanic white women.
Yeah.
And wait, where did you do this PowerPoint?
So at our residency, we have sometimes the responsibility to do journal club, and so I took this opportunity to educate my colleagues regarding not only about improving our knowledge in the medical field with healthcare disparities, but also really giving life examples of Serena Williams and other Black females. And so I did this PowerPoint presentation for our journal club during residency. And so I went through the statistics and then included a journal article to highlight those things.
And did you get like any feedback that was unexpected, or just feedback in general about it?
No, I think a lot of people were very excited to discuss this topic. I think there was great discussion. A part of having this discussion, it's tough, right? Because it's on race and it's implicit bias. And again, people a lot of times feel ashamed and it's hard to discuss. So I think when you're focusing and saying, hey, Black women are dying, and it's more to it than just access to medicine, access to or education, and it's more about racism, sometimes people get very defensive. And so some of that did come out in the discussion, but you need to have that, right? You need to be uncomfortable. You need to have these discussions because change won't happen. If we keep pretending that, we're all the same regardless of our background, then that's where you're going to get this number where 43.5 women or number of women are dying per 100,000 births compared to 12 of if you're white. These numbers don't lie, and and I don't want to keep sounding like a broken record, but it's as a Black woman, again, it makes me emotional because I want to make sure that when I have children that I'm going to be safe and I'm going to be alive, to be there for them. And it's no guarantee. It doesn't matter if you're educated. It doesn't matter how many degrees I have behind my name or how much money. If no one's listening to you, then there you are. If you're getting discriminated against, you can't. How do you fight that? So
yeah. I mean, I think that that is a great. That discussion is great about just wanting better for us than we do have right now. And you could say that for anything, not just childbirth, but you could say that for just healthcare in general, because, you know, as a general medicine doctor, like there's there's higher rates of high blood pressure and diabetes and high cholesterol for Black compared to white. There's higher rates of STDs for Black compared to white. Like, so there's so much, just not childbirth, that is worse for Black people compared to white. So, but yes, I don't want to be. Don't want to be that statistic.
Mm-hmm.
Yeah, I definitely, as an audience member for Dr. Davenport's journal discussion, I think it, like she said, it sparks interest, it sparked a dialogue. From that discussion, we were able to initiate within our program a diversity and inclusion committee to make sure that we're trying to address some of these issues and come up with solutions by increasing diversity, by continuing to address these healthcare disparities, making sure that everyone feels inclusive within the medical environment.
Yeah,
that's exciting to hear, because it's an important topic, and I'm glad it didn't fall on deaf ears.
Yeah. And why do you think it is so hard for us to have a discussion around race and healthcare?
Denial.
Right. Shame, guilt.
Yeah.
You know, like, this is a bigger conversation
I
than
know
just
this is.
healthcare. Race in America, we have a long history of discrimination. And if you are not the privileged, and if you are the privileged and you don't really have a reason to think outside of yourself or your privilege, it is hard to be uncomfortable and to have to put yourself in someone else's shoes who constantly is not privileged and has to constantly think about race. So when that person who's privileged is taken out of their comfort zone, it makes it hard to have these discussions. I think minorities, and I don't want to speak on everyone, but I think we're more open because, unfortunately, we are constantly faced with the reminder that we are a minority, the constant reminder that we suffer from these things, or we're going to experience these things. So we're all constantly uncomfortable. So to have this discussion, I'm more open because I'm uncomfortable, because I'm usually the only one in the room, or I'm always uncomfortable. So it's
So if I'm
easier.
uncomfortable, everybody else could be uncomfortable.
Exactly.
Yeah.
But you have to be okay with being uncomfortable. I think but that's why it's difficult to have this discussion, because no one wants to be uncomfortable.
Yeah. Yeah. And like speak up for what they know and understand to be true for themselves. Like, I feel like, to admit um, just to admit things, like to be honest about whatever biases or I feel like that is hard for people to do. Just be open and honest with others that they don't know what their reaction is going to be, but to be open and honest with other people. And I feel like that is the hard step to have. Yeah, that's a really hard step. Coming back to patients in general, especially within the realm of pregnancy and childbirth, how do we, how can someone find a good advocate for themselves? Like, find a good provider that will listen to her concerns or just anyone's concerns?
A lot of times when patients are looking for healthcare providers, most of the time, I think we all usually have access to some type of internet. A lot of times you can look up the person that you've been referred to, that has been named as your primary OBGYN, so that you can read about their background. A lot of times they have pictures. You can see if this is someone that you would feel comfortable with, just based on, do they look like me? Is this someone that I feel like, that I think that I would be okay with having as my provider? You can read some reviews from patients that have had care with the provider to see if this is someone that, okay, this is what I'm looking for. And if after you meet with that person, if you don't have that rapport, or you don't think that you're going to have that chemistry with that provider, then you need to say, you can say to that provider, you know what, actually, I don't think this is going to work. And is it possible for you to refer me to someone else?
Yeah.
And that, if you don't feel comfortable doing that, you can talk to your insurance company. You can talk to the clerk or whomever and say, I want to have another doctor, or I want to have another provider.
Yeah. Yeah.
I mean, in addition, thank you, Dr. Johnson. In
Yeah.
addition,
I know you have to go, right, Dr. Johnson?
Yeah, sorry.
Well, thank you for being
so
on the podcast. And thank you for talking about this very important subject about healthcare disparities.
yes, thank you.
It's definitely important. Thank you.
All right. Bye.
Bye.
Just to address your previous question regarding what patients can do so that they get the adequate care as their counterparts. Like she said, doing background research on this physician, but then also it doesn't. Even though you're a person of color, you don't necessarily have to have a person of color as your physician.
That's
really,
true.
in that first interaction, does this doctor listen to my needs? Are they addressing my needs? Are they listening? Are they providing me with what I think I deserve? And if they are, then you continue your care. If you feel like they're not, then you can move on. And yes, if you want to use a minority as a criteria for the type of doctor you want, that's another aspect in itself. But I think it really boils down to, do you connect with this provider or this physician, and are they giving you the needs you deserve? And if they're not addressing your needs, then you just move on.
Yeah.
And be your own advocate. Yeah.
Mm-hmm. And you know what I have seen just in doing searches of my own is that there isn't really a good system to find a doctor. Yeah, you can find it through insurance, and that's kind of the only way. And sometimes they'll give you reviews, and sometimes they won't through the insurance. Right. And so I feel like there's not a good way. I oftentimes hear people asking me like, hey, do you know an OBGYN, or do you know a dermatologist, or do you know a whatever doctor? And sometimes if I do know them, I'll send the patient to that provider, but it's usually insurance, or it's usually some barrier getting in the way between that patient and seeing that provider. So I feel like there's not the best system for looking for a doctor, and also seeing their reviews and just getting more information about them. Like, I feel like there's no real system or good system in place.
Agree. And I think medicine is a little slow in terms of being technological advance. I think in due time, it will be a lot easier to find a physician. You'll be able to look up their profile and see all the different like their ratings. I think there's a website, Vital Statistics. There's Yelp pages now. But really, when you move to a new city, it's about, okay, how I usually find physicians or dentists. I use Yelp. I use whatever providers through my insurance, and then looking to see who they have treated or what they can provide. But I agree, there's not an easy way or to find that physician that can take care of you. It's really a throw of the dart into the wall and hoping you land on someone. It is a difficult. I agree. Process.
Yeah. Well, there are things that definitely need to change. There's a lot of things that need to change within the healthcare industry, regarding implicit bias, regarding access to care, and regarding just the list of things that we talked about earlier, with minorities getting the same healthcare, or having the same healthcare outcomes as white people. And so I thank you, Dr. Davenport, for being on with me. And usually what I end with is, because this is called Viva La Vulva, and we talked about, pregnancy and childbirth and the health disparities from that perspective. Can you leave the listeners with anything uplifting or empowering or any knowledge about the vulva?
Any knowledge or empowerment? Sure. Well, I'm definitely, an OBGYN, and so I am all about the vulva. And I think if women are more educated and informed about what goes on with their vulva, they'll have a better outcome. So I encourage women to learn, not be ashamed, not to be, not to feel anxious, but to go into your OBGYN and have those frank conversations, whether it's from pain with intercourse, pelvic pain, just in general, abnormal bleeding. Your OBGYN is your advocate for educating you on your health and also addressing all your concerns. So I say, go out there, take a mirror, look at your vulva, and then go into the OBGYN and get some questions answered. So there you go.
Yes. Do you do anything with the mirrors? Like, do you use mirrors in your discussion with patients?
I haven't been, but that's a good supplement to the education. I use a lot of not necessarily props and
yeah, like pictures and diagrams and things like that.
Correct. And I educate because a lot of women don't know that they have 2 ovaries, 2 fallopian tubes, 1 uterus, and a cervix. And so I really, when I'm educating, I'm a visual learner, and I feel like a lot of people are nowadays. So I use that. I tell people to go to websites, but I haven't really necessarily used mirrors, but we probably should.
Mm. Well, thank you again for being on the podcast, and I do appreciate you and talking about this very important topic.
Well, thank you for having me, and I'm pretty sure Dr. Johnson appreciates you having her. Thank you.
Yes. So this has been another episode of Viva La Vulva, and to subscribe, you can click subscribe in iTunes. I'm still getting Google Play, and there's another platform underway, but once we get it underway, then you can access it, or iHeartRadio. You can access it there. But feedback online, you can give it to us at on social media at Viva La Vulva LA. And I just thank you for listening to another episode of Viva La Vulva. Bye.
Bye.